Okay, awesome. Thank you for joining MNAAP and Alongside Network today for the third webinar in our three-part series. Today we're going to focus on applied strategies for responding to pediatric medical traumatic stress and resisting re-traumatization. So I am going to pass it over to Jen, founder of Alongside Network.
Thanks so much, Hannah. Really glad to be here today and just thrilled to be partnering with Minnesota Academy. I always say this wrong. Minnesota chapter of American Academy of Pediatrics. So sorry. Yeah. And with Dr. Tess Smith Thomas on this series. I'm Jen Aspengren. I'm the founder and director at Alongside Network. And our work is really focused on both supporting families directly following incidents of pediatric medical traumatic stress, and then also looking to reduce pediatric medical traumatic stress among caregivers and in hospital visits. So very glad to have you all with us today and really thrilled to be able to introduce Dr. Tess Smith Thomas. Dr. Tess Smith Thomas is a licensed pediatric psychologist and assistant professor of pediatrics in the College of Medicine and Kentucky Children's Hospital. She provides clinical care to children and families experiencing difficulty adjusting to an injury or illness. Dr. Smith Thomas utilizes evidence based treatment approaches to reduce symptoms that may be interfering with medical care or life more generally. Dr. Smith Thomas is also committed to conducting applied, clinically relevant research alongside and related to her clinical work. Broadly, her current program of research focuses on improving psychological outcomes for children with medical conditions through developing refined screening approaches to better identify children at risk, reducing disparities through equitable dissemination of resources, and third, increasing treatment efficacy by developing tailored interventions. She's also conducted a body of research focused on investigating etiological models of early childhood behavior disorders in order to improve diagnostic assessment and intervention. Dr. Smith Thomas also collaborates with the Center for Pediatric Traumatic Stress to implement trauma informed care throughout the medical setting. So, thank you so much, Tess. We'll pass to you. And thanks for everyone for joining today.
All right, thank you for that introduction, Jen. We can go ahead and dive in. So, our objectives for today are to identify strategies to support families experiencing symptoms of medical traumatic stress. We'll discuss approaches for discussing emotional health and trauma reactions with families and learn some applied skills for resisting re-traumatization by reducing traumatic aspects of care. And so this is part of a three-part series. This is the third and final part. And so I'll start with just a quick recap of some of the things that we've covered in the previous sessions that give kind of a nice context and background to get us started with these more applied strategies. So just as a refresher, pediatric medical traumatic stress is a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. And so we really can think about medical traumatic stress as these emotional reactions to medical stuff, essentially. And so when we think about medical traumatic stress and responding to medical traumatic stress, we can utilize SAMHSA's 4 Rs and their trauma-informed framework, which highlights that it is important to realize the widespread impact of trauma, recognize the signs and symptoms of trauma, and then respond and resist re-traumatization. And so we've kind of used this framework throughout this three-part series. Thus far, we've focused on the realize and the recognize, and today we'll be talking about the final 2 Rs. So just as a recap, when we talked about realizing the widespread impact of trauma, we discussed both the traumas that our patients may already walk into our care with, and recognizing and realizing that widespread impact. We learned that 75% of high school students report experiencing one or more ACE, as well as 20% experiencing four or more ACEs. And so when we realize that, we also realize that the majority of the patients that walk into our space are going to be presenting with some sort of existing trauma history. And then, in addition to that, we also need to realize the widespread impact of medical traumatic stress specifically. And we learned that 30% of children experience significant traumatic stress reactions across illness and injury groups. We learned that 20 to 30% of caregivers experience these persistent traumatic stress reactions, and about 15 to 25% of siblings experience persistent traumatic stress reactions. And so, not only are we realizing the pre-existing trauma, but also what could potentially happen while they're under our care, and realizing how this impacts not just our patients, but also our caregivers and their siblings and kind of anyone that interfaces within the system. And prior to this three-part series, we also discussed secondary traumatic stress in a two-part webinar series. And that is also kind of a large component of implementing trauma-informed care. So after we discussed realizing the widespread impact, we talked about recognizing the signs and symptoms. And we really discussed kind of these four symptom buckets when we think about trauma reactions. So that includes things like re-experiencing, which may be intrusive thoughts or memories about an illness or injury or medical procedure, including nightmares or flashbacks. We also talked about avoidance, things like maybe avoiding medical treatments or avoiding the hospital or doctor's office in general. Also avoiding just general thoughts and feelings about medical conditions or conversations about medical experiences. We talked about hyperarousal, which is kind of just this like feeling of hypervigilance or being on guard, being really easily startled or jumpy in a medical setting, or this kind of like heightened sensitivity to environmental stimulus. And then finally, we talked about that fourth bucket of symptoms, which is changes in cognition or mood. And this includes things like persistent feelings of shame or guilt. This might include anger or confusion, fear, sadness, worries, those kinds of things. This can kind of evolve to just these negative thoughts about oneself or other people or the world. So thoughts like the world is an unsafe or scary place, or all people are dangerous. And so these are kind of those four buckets of symptoms that we are looking for when we think about those persistent medical stress reactions. But we also talked about recognizing what is happening physiologically in patients' bodies when they're experiencing trauma reactions. And so we talked about how various parts of our brain and bodies are in kind of this constant communication with one another, and with our environment or external stimuli. And when we're in a really stressful or dangerous situation, our senses send signals to the amygdala, which then sends a signal to our hypothalamus in our brain, which communicates with our nervous system. And that nervous system then releases stress hormones into our body. And then the adrenal glands kind of pump epinephrine or a stress hormone through the bloodstream that signals our fight or flight response. And our fight or flight response can then cause kind of a plethora of physiological symptoms, things like increased heart rate or blood pressure. And then our bodies and our immune system, our systems kind of experience all of these intense reactions of stress. And so this is really what is happening for our patients when they are recognizing or perceiving a medical experience as stressful or dangerous. Okay, so that was our recap. Let's go ahead and dive into our final two R's in trauma-informed care, which is responding and resisting re-traumatization. And so when we think about this, we can kind of think of these six guiding principles to kind of guide our trauma-informed care. And so the Center for Pediatric Traumatic Stress co-created this handout with Boston Children's Hospital's Pain and Stress Studies Lab. And this handout really highlights SAMHSA's six principles of trauma-informed care. So the first of those is trust, building trust with our patients. And one way that we can do that is by acknowledging the history of trauma, but then also respecting patients' decisions to either discuss or not discuss those events with us. And so that can help build trust. And I think that this is a really important component to trauma-informed care. Another principle is empowerment. We can empower our patients and their families by providing reassurance and giving realistic hope. Um, Another really important guiding principle is peer support. So we want to engage any sorts of peer supports by empowering caregivers to identify supports that are helpful for their child, encouraging connection for both the child, the caregivers, and siblings to support groups that exist for certain illnesses or injury groups. And so, building on those peer supports is a very important component to trauma-informed care. Safety is kind of another guiding principle that we like to talk about. And the way that we create safety is through screening for ongoing distress and referring if we are recognizing higher levels of distress. We want to acknowledge the distress and then provide outlets, and that might be providing, families with some different techniques or coping strategies. That might be kind of engaging existing supports at your institutions, such as chaplains or child life or mental health professionals, but building that environment of safety. Something that leans well into that is another guiding principle, which is culture. And when we think about that, we're talking about utilizing appropriate gender pronouns, recognizing and monitoring your own biases and stereotypes, and how those might be at play for our families that are interacting with our medical systems, identifying key decision makers in a family based on the family's culture. And so that might look different for different people. And so this is kind of a way of providing a form of personalized care where we recognize a family's background and culture and take that into consideration without judgment, as well as by kind of empowering those aspects and facilitating those supports that may exist. And then finally, the last guiding principle is collaboration. And so, in trauma-informed care, I think collaboration is one of the more important guiding principles. We think about providing choices and a sense of control to our patients. That might look like providing the ability to choose the gender of our provider, or having a support person present during exams. That might look like offering to limit the number of providers that are in a room if that's becoming really overwhelming for a patient. That might look like asking for permission before touching a patient for a physical exam. And I think some of these things can be difficult to implement in the medical setting because providers are often already overburdened and extremely busy. But providing these types of collaboration and these small choices when possible can really make a difference for our patients and families and impact whether or not they experience their medical care as traumatic. And so we'll kind of expand on these kind of 6 guiding principles a bit further, but I think that this is a really good starting point. So I want to introduce you all to the Pediatric Psychosocial Preventative Health Model. This model is really based on the premise that all families should receive psychosocial care. This should be kind of a standard practice. And also family psychosocial risk can kind of be understood to fall into like these 3 tiers or categories. And each of these tiers have different implications for care. And we can kind of think of, trauma-informed care is really going to be relevant to all three of these tiers, but it can kind of be conceptualized as a part of universal care. And so, universal care, that kind of bottom blue tier, is um, the kind of tier and level of interventions that are implemented for all children and families. These are families that we would kind of consider like they may start out a little bit distressed, but they're really resilient, and they're not going to have persistent traumatic stress reactions. And so, universally for all families, part of trauma-informed care would be providing psychoeducation and family-centered support and screening for indicators of high risk. We want every family that interfaces with our system to receive those universal interventions. Moving up a tier to the targeted level is more of our families who are experiencing more acute or elevated distress in the beginning and have other risk factors present. And for individuals falling into this targeted category, we are going to monitor the child and family distress as well as their risk factors. And we may provide some small interventions for specific symptoms or adherence needs. And then finally, that top tier is going to be far fewer families, but these are going to be our families that are experiencing those more severe or escalating or persistent distress symptoms. And these are families that really would qualify for or need more clinical interventions or treatment interventions. And so for these families, we might be consulting with behavioral health specialists or intensifying like the psychosocial services that are interacting with the family. And we're going to really address the impact on medical treatment. And so when we think about this model and trauma-informed care, um, healthcare professionals are really going to be focused on that universal tier as well as a little bit the targeted. Our mental health professionals are really going to be focused more, they're going to provide interventions at all of these levels, but mostly at that top level is where we really need to engage our mental health supports and our psychologists or social workers to support the families. But at the universal level, that is really where kind of our physicians, nurses, and kind of all the providers interfacing with the medical system can make an impact and a difference. And so today we're going to be talking mostly about some universal things that you can implement in your care to support a trauma-informed care perspective and reduce medical traumatic stress for families. All right, so the Center for Center for Pediatric Traumatic Stress, gosh, I totally stumbled over that, really developed this kind of DEF framework for healthcare providers to kind of guide responding to medical traumatic stress. And so medical providers have like the ABCs, which is like, I always forget this, like airways, breathing, circulation, the things that are really important for like living and survival. And we suggest that after those ABCs are managed and kind of stable, we then need to consider the DEFs. And so the D stands for distress. The E stands for emotional support, and the F stands for family. And so we're going to dive deeper into kind of these DEFs, but this is going to be our guiding framework for responding and resisting re-traumatization. All right, so how do we assess distress? When we think about distress, we're going to think about a few different categories. One of those is actual pain, right? Pain causes distress, and in our recognizing part of the series on recognizing signs and symptoms, we talked about risk factors and high levels of pain during medical care is one of those risk factors for developing medical traumatic stress. And so pain is something that we definitely want to be assessing. How do we assess it? We ask some basic questions, right? So we ask, how is your pain right now? What was the worst pain that you've had since this happened, right? This is kind of another way of asking that question and assessing, is there something significant that stands out for our patients and families as painful? And are they experiencing those ongoing levels of pain that are going to put them at risk for maybe more targeted interventions rather than our universal interventions, right? We are going to assess distress in the fear and worries category. And so in that category, we might say something like, sometimes kids get really upset when something like this has happened. What has been scary or upsetting for you? Or what's worrying you the most? And asking some simple questions to kind of assess what kinds of fears are they experiencing, what worries are they experiencing, is going to be another really great way to indicate to us as providers how our child, patient, and their families are experiencing their medical care. And so we also know from that previous recognized session that one of the best predictors of the development of these medical traumatic stress symptoms is the perceived perception or cognition about the medical care. Was the child afraid for their life? Were they worried they were going to die? And did they experience it as a significant threat? And so these kinds of questions, asking about fears and worries, is going to get at that. And again, help you decide, okay, is this someone that we can just kind of continue on with these universal interventions that we're doing for everyone, or do we need to engage more support? And then finally, when we are assessing distress, we want to be thinking about grief and loss. And so if this was some sort of accident or kind of community-based event, was there anyone else hurt, or is anyone else ill? Or do you know anyone else who has experienced this illness? Have you had any other recent losses? This isn't necessarily just related to the event itself, but this could be family members. This could be pets that have been lost recently, or family friends. But what other kinds of things are you experiencing related to grief and loss that could impact how you're going to perceive your medical care and impact your current coping? How do we help with this distress? So we assess it. How do we help with it? So one of the things that we can do, and I touched on this in that collaboration guiding principle, is providing control. The ways we can do that is by helping a child understand what is happening and why it's happening. Um, so it's really helpful for a child to kind of get the why behind what we're doing. We're not poking them just because we want to be mean and we want to poke them, right? We are poking them because we need to get blood to see how X, Y, and Z is doing, or because we need to give you this shot to make sure that your body doesn't get sick. And so providing that understanding and helping a child understand the why can be helpful, as well as allowing the child to have a say in what will happen next. Now, when I say provide control, I don't mean that the patient is in charge and what they say goes, right? What I mean is that are there ways that we can provide small choices that give a sense of control to our patients and families, even if ultimately like there are certain things that they have to do. And so kind of a really simple way to think about this is like, okay, do you want to take your medicines right now, or do you want to take them in 5 minutes? Do you want to step on the scale at the beginning of your visit, or would you rather do that at the end? And giving them a little bit of sense of control. It's not, do you want to do this? Because I mean, the answer is probably going to be no. But more so like, when do you want to do this? And giving a small choice and a sense of control where you can. That can really help with the distress. Another way to help with distress is actively assessing and treating pain. So again, we touched on assessing the pain. Now we are going to respond to the pain. We are going to use our hospital's pain management protocol. If you have a pain specialty team, engage them, get them involved. They're the experts in the pain, right? And so engaging those kind of levels and following protocols to support pain management is going to be really important, even if you, as a provider, don't perceive that the patient should be experiencing the level of pain that they're experiencing. Yes, we need to be mindful of like seeking out medications for pain management, but I think it's also really important to rely on the experts who can kind of assess that and make sure that we are addressing pain if our patients report that they are experiencing pain. That also might include teaching children and parents basic coping techniques for pain, non-pharmacological strategies that might involve engaging child life or a psychologist at your institution to teach some of those strategies. Or if you have some ideas yourself, things like distraction or a really simple breathing technique can really help with pain. Again, it may not make a ton of difference, but it is going to give the patient a sense of control in their pain as well. And that can be really helpful. Another way to assess distress is by, or to help distress is by providing accurate information and using really basic words. I think with kids, this can be challenging to do because a lot of things that are occurring can be really complex. And it is a skill to learn how to communicate those things effectively to a child. And so, something that can be really helpful for that is asking the child to repeat back explanations that you've given. That way you can really kind of gauge, okay, what are they understanding? What did they pick up on? Did something that I say really stuck with them? And maybe that actually wasn't the most important point that I was trying to get across. So checking back and having them repeat back to you what they heard can be really can provide a lot of insight into what they're experiencing. And then listening carefully and clarifying any misconceptions. And then finally, providing reassurance and realistic hope is going to help distress. So, describing what's being done to help the child feel better. So, I hear what you're saying about your pain. Here's what we are going to do about it, right? You're going to describe what we are doing to kind of address their needs. And then, really, just like I said, addressing their concerns or worries. Oh, I'm hearing that you're really distressed about this. Like, okay, well, you know what? We actually have a child life specialist who can kind of walk you through what that procedure is going to look like. Would that be helpful for you? Or, oh, I hear that you're like really struggling with the loss of someone in your family. We have chaplain services that they might be able to stop by and have a conversation with you. Do you think that's something that you would find helpful? And so addressing any concerns or worries that they bring up is going to help decrease that distress. So that is our D of the DEF protocol. Next, we're going to move on to E, which is emotional support. And so first, we're going to assess it. How are we going to assess it? We're going to ask some questions. So here we're really thinking about what does the child need now? Who is available to help the child? And what kinds of barriers exist to mobilizing those supports? So what does the child need now? Asking a parent, what helps your child cope usually? Or asking the patient themselves, what helps you feel better when you're upset or scared? Finding out who is available to help the child. You may just see if parents understand the illness and injury and treatments that are going to occur. Do they understand what is happening? Are they able to be there with the child during procedures? This is really, really important. One thing that I've learned as a pediatric psychologist is that um, caregiver distress can skyrocket child distress. And so there are times where it is really, really helpful to have a parent present during a needle stick. And then there are other times where having the caregiver present actually just escalates the child because the parent becomes so distressed themselves. And so maybe mom isn't able to be in the room during the needle stick, but maybe dad is able to be there. Or maybe the child does better if the child life specialist is there and there isn't a family member that they're more familiar with there at all. And that's going to look different for every family. So recognizing and assessing, okay, who can actually support this child in the moment? Um, and are they able to kind of help calm and soothe? If you're distressed yourself, you're probably not going to be able to help regulate someone else's emotions. And so I think that that is really, really important. Um, and then finally, what are the barriers to mobilizing support? So we kind of already talked about, are their own responses making it hard for them to help? Or how confident is the parent in caring for their child? This is also really important because um, sometimes it isn't that they're not able to regulate their own distress. Sometimes it's that they don't know how to help. And so sometimes it can be really helpful just to give parents some coaching on, oh, here are some ideas of things you could try to support your child. So, how to help with the emotional support? We need to listen to parents and encourage their presence. So, asking them about their expertise about their child. Caregivers know their children best. And so we can rely on them for what they know about their child and what might be helpful for them. We also need to ask parents about their own concerns because even though a child may not be having a specific concern, if the caregiver is, that is also something we need to address. And then just encouraging caregivers to be with their child. We can empower parents to help their child by suggesting ways that they can help. We can involve them in physical care as appropriate. Sometimes it can be a really nice way to provide caregivers a sense of control, especially in the hospital setting, to have them be engaged in their care. And sometimes caregivers actually really find that to be really helpful of like, oh, okay, here's how I can help my child right now. They need X, Y, and Z, like I can do that. And then also like helping and empowering caregivers to seek out support if they are struggling. And then finally, we can encourage both the child and the parent to engage in what we would call kind of like their normal activities. So suggest activities that fit with the child's medical status. Finding activities that the child and the parent can do together. Okay, if we're kind of stuck in the bed, can we engage in a board game or a game of Uno? Promoting contact with child's friends and teachers, I think, is another way to kind of provide that sense of normalcy. But we know that when we provide some of that sense of normalcy, those trauma reactions decrease, and that can be a really helpful way to mitigate traumatic stress. So let's move into the F, which is family. So how do we assess how the family is doing? And this is really important because as we talked about recognizing and realizing medical traumatic stress, we did talk about the widespread impact for caregivers and siblings. And so this is a really important component to trauma-informed care that we can't overlook. So we assess kind of our patient's distress, we engage emotional supports, and now we need to check in on everyone else. So the way that we do that is by assessing distress of parents and family members. So how's your family coping right now? Or who is having an especially difficult time with this? Gauging their stressors and the resources that exist. So are you eating? Are you getting sleep? Are you taking breaks? Or have you not left the hospital since your child's been admitted? Do you have friends who can come help out at home? Um, oh, you've got another kiddo at home, like who can help support with that, right? So gauging what other stressors are at play. And then addressing any other needs outside of medical care. So, are there other stressors going on, things like money, job, transportation, that are making it particularly difficult right now? And if there are, can we help address those in any way? There may not always be a resource to address those needs. Sometimes there are. When there are, that's great. We can engage our social workers and we can try to help get some resources to the family. That isn't always the case, but that doesn't mean that we shouldn't ask about it because even just providing that space to talk about it and listen and kind of provide reassurance can be helpful. And so that is another thing that we do want to assess. So, how do we help the family? We encourage basic self-care for parents. We want to encourage them to sleep, eat, take breaks. And we want to help them enlist support from family, friends, and their community. They don't have to do all of this on their own. We want to remember other family members' needs, so trying to involve siblings and explain treatments when possible. Sometimes caregivers can find it so helpful and relieving to offer to explain to a sibling what is happening with their brother or sister that's in the hospital. And that can kind of take that weight and burden off of the caregivers and can be really helpful for the families. We can also enlist the hospital resources, like I mentioned, chaplain, social workers, child life specialists, or psychologists as needed. And then finally, we want to be sensitive to the cultural and resource needs of the family. So we want to remember that outside issues can impact recovery. Things that are happening in the family can impact whether or not a child or caregiver or sibling will go on to have those persistent traumatic stress reactions following a medical event. And we want to be open to involving other healing professionals and customs that are related to families' cultural beliefs and practices. And so you can kind of see how those six guiding principles are intertwined throughout this DEF protocol and can provide a really clear way to respond to medical traumatic stress and prevent re-traumatization. So, what do we do when we recognize that these symptoms are existing and someone needs that higher level of care, that clinical or treatment level? We're going to refer for additional support. And I think this can be intimidating for a lot of providers because, especially if we know from like the family's cultural background that there may be some resistance to this. I think that referring for additional support can be somewhat intimidating. And so, the Center for Pediatric Traumatic Stress created this really nice flow sheet that you can use. One, to determine if you should make a referral, and two, kind of how to make that referral. And so we're going to ask and we're going to listen. And then if any of the following are present, so if those reactions are severe or prolonged, if they're interfering with recovery or returning to usual activities, um, if they're interfering with treatment adherence or their ability to engage in their medical care, if there are new fears or worries, or really concurrent severe stressors without social support, then we might want to make those referrals. And I think that really the way that you do this is just by mentioning the concerns that you've identified. Hey, I've recognized that, you've kind of been experiencing a lot of stress and you seem really distressed when you come in for your appointments. And actually, it seems like it might be impacting your ability to take your medications regularly. Um, and you want to involve the child and family in making that plan. There's something called like keeping the door open, which means even if the answer is not right now, maybe it's not a no, right? Maybe the no is just not right now. And so keeping that door open. I know you have a lot on your plate right now, so it may not be the best time, but I want you to at least think about it and consider it. And we'll check back in about it the next time you come in, right? And promoting kind of continuity of care. So this is a way that you can kind of make that referral. I'm going to briefly touch on some additional resources. So the National Child Traumatic Stress Network partnered with the Center for Pediatric Traumatic Stress to create a full-blown toolkit for healthcare providers on medical traumatic stress. And so you can find that online. It looks like this little image here in the first box, but it is a full toolkit and it has worksheets that you can provide to families. It provides a lot of information about how to provide psychoeducation and how to screen, and really covers a lot of the things that we've talked about in these series. So if you want to kind of learn more about trauma-informed care, that is a really great resource for providers. Um, healthcaretoolbox.org, again, I can't recommend that resource enough. It has tons and tons of resources for providers, as well as families and caregivers. So you can direct families and caregivers to healthcaretoolbox.org. You can go on there yourselves. There are some free CEs on trauma-informed care as well on the website. Lots and lots of resources. Basically, anything that you need to know about medical traumatic stress, you can find on healthcaretoolbox.org. I want to recommend a book that was written by a colleague of mine, as well as a caregiver of a child with Hunter syndrome. And so that book is called Afraid of the Doctor: Every Parent's Guide to Preventing and Managing Medical Trauma. This is a fantastic resource for caregivers. I think as a provider, it's a nice thing to kind of have in your toolbox that you can recommend to families. And then finally, for kids who have experienced an acute injury, after the injury.org is a website that was developed by folks over at the Children's Hospital of Philadelphia. And there are lots of resources on there for caregivers of children and teens that have experienced an injury. And so that is another really great resource that you can provide to families. There are things like screeners on there, as well as worksheets and kind of different tools and how to support your child if you're concerned about trauma reactions that they might be having after an injury. So I'm going to quickly go through a case example in these last few minutes about how we might implement this DEF framework. And so Robbie is a 9-year-old who has been hospitalized for about 5 days for an acute respiratory illness. And he has been able to kind of wean down to 2 respiratory treatments a day. Overall, his health really seems to be improving. He's doing much better than he was when he came in. But during rounds, the family shares with you that he's been really withdrawn, and they're really concerned that he's actually becoming more ill just because he's refusing to kind of engage in activities that he normally loves. He doesn't want to do anything, and he just seems really lethargic. And so they're worried that this medical plan isn't actually working, and they're concerned that he's getting sicker. And so you're going to engage the DEF protocol. And so you're going to start with distress. So you start by just asking, like, all right, Robbie, are you having any pain? He denies pain. He says pain, he's not having any pain. So then you ask, all right, Robbie, like what is worrying you right now? And Robbie then actually shares with you that he's scared. He's afraid that he is not going to ever be able to go home, leave the hospital, and he's actually worried that he's going to die right there in the hospital. And so learning this, you are then able to provide Robbie with some reassurance that his illness is actually currently improving, that you're giving him medicines that are helping him, and you're actually really hopeful that he's going to be able to go home in a few days. And you also share with Robbie that you have seen several other kids with a similar medical illness that have made a full recovery and are kind of outliving their lives and are very healthy. So you provide that reassurance, right? You ask, you assess the distress, and then you were able to reassure him. Next, you move into the emotional support. So you ask then his parents and Robbie kind of what generally helps Robbie when he's scared or upset. And Robbie talks about spending time with his dog at home and how that really makes him feel safe. And that's kind of where he goes when he needs comfort. And so you then are able to encourage the family to show you pictures of their dog. Like, hey, like, do you have any pictures? Can you show me what your dog looks like? And you kind of see Robbie a face light up a little bit. And you encourage the family, like, hey, maybe you could put up a picture of the dog in the room. And actually, Dad, when you go home later today, maybe you could FaceTime Robbie with the dog and let Robbie kind of interact with the dog over FaceTime. And then also, we actually have some emotional support animals that come through the hospital occasionally. So, let me check and see if we've got a dog that might be able to actually stop by. Would you enjoy that? And, Robbie says yes. And so you've kind of engaged some of those emotional supports, the things that generally help Robbie. And then finally, you're going to move to the family. So you're going to assess how's the rest of the family doing? And you ask, how's everyone else? Mom, And mom actually tells you that she's doing fine. She's just worried about getting Robbie well. And you're like, okay, but you press a little further and you ask if she's been able to take any breaks, like going home for a shower or a home cooked meal. And mom actually then admits to you that she's not left the hospital since Robbie was admitted 5 days ago. She actually hasn't even left the room. And you kind of encourage her to take care of herself and ask if there's someone that she trusts who could come and sit with Robbie for a few hours while she takes a break. And mom thinks for a minute and then she says, well, you know what? Actually, my best friend, who's basically like my sister, she lives really close by. And as mom's telling you this, Robbie's kind of smiling and asks if her friend's daughter could come too. Because, Robbie and her daughter are friends. So they actually stopped by later that evening. And then the next day, mom thanks you. And she says that Robbie was actually really happy to have a break from her. But also, he got to spend time with his friend's daughter who brought him some Legos and he played Legos. And mom said she was feeling pretty refreshed herself and she didn't realize how badly she needed that break. And she mentioned that the therapy dog had also stopped by yesterday. And mom said Robbie seemed much more like himself. She wasn't worried that he was declining from a medical standpoint anymore. And so this is just an example of how you can engage that DEF protocol. But I also want you to think about how would this family's hospital trajectory be different without implementing that DEF protocol? And could that approach have shifted and changed this family's long-term coping? And I think that it is pretty obvious that it probably did. And so this is why we talk about trauma-informed care. So I know that we are like at time. I think that I might have seen questions in the chat or comments in the chat. Oh, there were the resources being shared. Thank you so much
Yeah,
for sharing.
exactly.